So I'm Dr. Jo Naidoo. I'm a consultant psychiatrist in East CMHT over in Britain, and I also have a medical education role as well as recently appointed medical director for the Southampton division. I've been asked today to give you an overview of mental health services within the Southampton area, and I am joined by my colleague Emma, who will assist as well with regards to any questions. So it's really meant to be interactive, really, and help give you a one-stop, whistle-stop tour of mental health services locally. So let's get the most out of it. Any questions, please just raise your hands. Happy to address them as we go along. So just an overview about what our services aim to achieve and how we are hoping to support our local community. And I guess the priority has to be to promote and improve mental health and well-being. And this is core and fundamental to every part of the service within our mental health services. And we'll go through the different parts of mental health services so that you're aware of what sort of services are available. We aim to promote independence and self-reliance and recovery. Again, this is key. And these are huge words: independence, self-reliance, and recovery. It's really individual to each individual and each person. And whilst the services are geared towards helping and supporting an entire community, we also aim to try and ensure that it is individual and person-centered. And that also means that for those using the service, it's about having the autonomy and the ability, whether you do it independently or supported by family, carers, friends, to be able to direct and help us understand what you need. Because the sooner we understand what you need and what are your priorities, the easier it is for us to support you to achieve what you want. And I think sometimes what happens when patients come into the services, especially secondary mental health services, there is an assumption that you have to simply take what's on offer. And I think if you're able to help us understand what it is you need, again, we can personalize and ensure that you have a very person-centered care plan. We also aim to promote responsibility and citizenship. So again, it's very much about maintaining your independence, ensuring that patients have and maintain their own responsibility for things that are going on around them, and not absolving individuals of responsibility depending on the situation at hand. We aim to improve the quality of life for our service users, their families, and carers. And I think this is key. We've certainly learned through mental health services how vital, in terms of a recovery model, it is to ensure that family members and carers are an integral part of that care plan, and that their views, opinions, and outlook, and even collateral information or understanding of what's going on for a patient is taken into consideration. That not only helps us direct the care plan that is then formulated, but families and carers, together with the patient themselves, are able to input into that care plan. And again, if you think about what it can be like experiencing mental health challenges, it's very specific to an individual, and what family and carers may be seeing may differ slightly, but equally so relevant. And again, this treatment success plan is often when you have a triangulation of care where you are able to look at the services that are involved, the patient that is being described or looked after or supported, as well as their family members, carers, are involved in their difficulties or in their challenges and supported. To assist individuals to remain within communities and networks. And again, this is vital. And I think, there used to be a time where it was assumed that if you were struggling with mental health difficulties, and inpatient care or going into a facility was deemed what was necessary. And what we've also come to understand is taking people out of their environment and putting them into an environment that in some ways is quite protected is not always useful and helpful. Because at some point we have to return, don't we, to whatever challenges we were struggling with initially. So as much as possible, there is really a drive to keep people at home in your communities and help develop the skills that you may need to cope within that situation and circumstances. And the evidence certainly supports better patient outcomes if we are able to support patients in their communities and within their homes. We try and work collaboratively with both service users and their families. And again, we've spoken a lot about that, but that collaboration is key. And for patients as well as service users as well as their families to understand how best you can access that service and access assistance if and when necessary. We treat all individuals with dignity and respect, and this is key. You know, we live in a diverse culture and community, and as much as we possibly can, we are acutely aware of the importance of maintaining dignity and respect, as well as ensuring that everybody has access to an equal service. So, self-referral services, we have a few ways in which this can happen. We have our 111, which is access to physical and mental health service and support. This is the 24/7 service, and I will break it down and talk a little more about the Lighthouse, which is next, regarding mental health crisis support. And I think it's key to understand that, you know, the reality is we don't necessarily need services only 9 to 5. We recognize and realize that often, you know, we find ourselves in difficult situations outside of working hours because that's human nature. So we needed to make sure that we had access to, and our service users had access to, support during that time. And the Lighthouse is often a really useful access to services outside of your usual working hours. And then we have enhanced mental health primary care services. So the Lighthouse. So the Lighthouse is open to those over the age of 18 living within the Southampton area. As I said, it opens between the hours of 4:30 and 11:30. And we've just opened a second service within the Bitton area. It's also really useful to consider visiting the Lighthouse, especially when patients are feeling overwhelmed or hopeless. If you need urgent mental health support, for those that may be struggling and having thoughts of not wanting to be here, thoughts of potentially doing something that might cause you some form of harm or ending your life, feeling isolated or alone, loneliness is really difficult. And I think during the pandemic, we all became acutely aware of the impact of loneliness. And it's certainly not something that we ever take lightly. Feeling confused about where to find support. Again, Lighthouse can be really helpful in supporting with regards to this. So enhanced primary care service looks at your access via your GP surgery. You can access either telephone or face-to-face service. This service provides advice and treatment regarding difficulties, and it became clear that with secondary mental health services having criteria in terms of how patients would move from primary care to secondary mental health, it was vital for those individuals that were seeing their GP or able to access their GP that didn't necessarily need secondary mental health services, but still needed some form of support or advice or treatment that may be required. And so the enhanced primary care service is often able to help a massive group of patients, to be honest, that felt like they were kind of between services at times. And if there were challenges or difficulties that warranted input into secondary mental health services, this would often be another avenue to access those services. Patients within the enhanced primary care service also have access to peer support, which is crucial and has had a massive impact in terms of mental health services. And I think Emma will hopefully give you a little more in terms of peer support. And I think what's been really helpful, and I've had patients say this to me, in terms of their ability to work with peer support workers, is being able to talk to somebody that you understand has had lived experience and truly gets it. Not somebody that you think may have understood it or researched it and learnt about it, but somebody who's actually experienced something similar to what you have. and can help explain things sometimes, support you in ways that actually seems to be directed towards what it is you may be needing at that time. And we've certainly had massive successes. We've had many support workers that are also integrated with our community mental health teams, which have proven to be of vital importance and actually crucial members of our teams. The enhanced primary care service are also able to offer brief psychological and informed interventions. And again, this is really important and helpful, as I think across the NHS, access to psychological services and access to psychological input has been a massive resource issue. So for many people that would benefit from it, accessing it isn't always easy. And having access to this now within primary care has been really useful, in terms of brief interventions. They are also able to offer group-based interventions, which again has been quite positively received. So let's look at how our services actually structured and what's the stepped care model. So at the top of the pyramid, you will see primary care, and this basically refers to primary care, GP access. So if patients develop some sort of difficulty and recognize they may warrant some sort of mental health intervention, or they are struggling with their mental health, the first port of call would be to access your GP, speak to your GP, help him or her understand what's going on and what your current needs are. If it is then assessed that you require secondary mental health services, this would be accessed from your CMHT or your community mental health team. Now, this is a secondary service, and often patients would need to meet what we call a list of criteria. But we need to see that actually, whatever is available within the community, which we understand, and whatever is available within primary care, which is significant, is not better suited. And the rationale behind that is the services available in primary care are excellent and easy to access. And I can't stress this enough, simply because, like any service, you don't necessarily have as much as you'd want to help the entire population. It isn't always possible. So you have to have a group of individuals that are able to support those that need it in particular areas. And I think what I'm highlighting is the services that are available within primary care are by no definition less intense than the services offered within a community mental health services. It's just easier access, and it's looking at the needs of the population as a whole, how you could roll out these programs to a greater number of individuals. So if patients are then deemed to be struggling significantly and warrant secondary mental health services, you would then come into the community mental health team. Within the community mental health teams, we have a structure of individuals. There's often consultant psychiatrists, there's doctors in training, we have other healthcare professionals, occupational therapists, psychologists, other care coordinators, and peer support workers. So it's a very multidisciplinary approach in terms of the individuals that are able to support within a community mental health team. Should we then find ourselves in a space where we've been doing what we can, we've looked at diagnosis, looked at medication, looked at support, looked at skill sets, psychological interventions, but if we find ourselves in a space where actually we don't feel that the situation is currently safely being managed within a community mental health team, we will then refer our service user to the CRHT, which stands for Crisis Resolution Home Treatment Team. And this is an intense service that is able to offer greater support within the community. So for example, within the Crisis Resolution and Home Treatment Team, you may have a practitioner who's able to support a patient who's struggling with compliance with medication, so struggling to take his meds regularly for whatever reasons. So they may have to come in and see you in the morning and in the afternoon, support you through that, work through skills sometimes, help resolve some of the challenges or work through some of the problem-focused interventions that may be helpful within that acute period where a service user is significantly struggling. They also have access to a consultant psychiatrist who sits within the team. So if it is about advice regarding medication, as I said, support, we have nurses that are also within both the CRHT and the CMHT that can also be accessed. So I think it's also important, within mental health and within health in general and the NHS, you can't look at any patient in terms of being silos, isn't it? We can't only look at the head, can't only look at mental health. We need to look at a patient holistically. And that means looking at their mental health and well-being, their psychological well-being, but also their physical well-being. So we have come to understand within mental health, again, medications have side effects, and that's a harsh reality. And sometimes taking meds has to be balanced off in terms of the benefit together with the side effects. And that could mean greater need for monitoring, making sure that if there's a physical health problem, that this is robustly managed, whether it's within mental health services, and often is done in combination with GPs or other services, cardiology, respiratory physicians may be needed, neurology, depends on what the situation is. And I think it's also an opportunity to coordinate care, because sometimes, when patients or service users are struggling with mental health difficulties, because a lot of the emotions experienced can be so overwhelming, and the presentation, again, so challenging and difficult for the patient themselves as well as their family and carers around them, that the focus can become purely on mental health. And actually, there's a lot about them. And so I think it's really important within our services, we do try and make sure that we're looking at a person holistically, looking at their mental health, looking at their physical health, their psychological health, also the health and well-being of their families and those loved ones around them. If this intervention within crisis resolution home treatment team, however, is for whatever reason, again, deemed inadequate, and we feel, and the patient feels that the risks involved or their current presentation is too severe to be managed within crisis resolution home treatment team, and patient can no longer be home and requires inpatient care, this is when a patient will be referred to hospital care or hospital treatment. And in Southampton, that's often at Antelope House. So access to secondary services. So patients can access secondary services either via their GP or via another mental health professional. Community mental health services are available to individuals who have, as I said before, a severe and complex or enduring mental health needs. We have 3 predominant community mental health services within Southampton, and in the centre here is Antelope House, which is our inpatient unit. So at Britain we have the East CMHT, which is where I work, and then we have College Keep, which is our central community mental health team, and it's based in town really. And then in Shirley we have Cannon House, which is the West CMHT, again fully functional teams. So let's look at the access of specialist services within Southampton. So whilst broadly we have our adult mental health services, we also have a need for other specialized services. So for example, those patients that are struggling postnatally, that have just had a baby and require a perinatal service, or may be pregnant and require perinatal service advice, we have our perinatal services. We also have our early intervention and psychosis team, and they look at patients who are presenting with a first episode of psychosis, understanding what may be playing a role, what's going on, is this substance related or cannabis related psychosis, what interventions would be really helpful, because we understand that if you are able to appropriately support and treat somebody with a first episode of psychosis, the outcome for patients are just more positive. They're able to, things like cognitive decline or memory or ability to function is much better if you're able to intervene earlier. So we have an early intervention service. We also have the homeless healthcare team. Our psychiatric liaison service is based at Southampton General Hospital. And this is a group, again, similar to the sort of individuals, nurses, medics, various other healthcare professionals that are based at Southampton General. And in the liaison service, should somebody come in for whatever reason to Southampton General Hospital, it might be an episode of taking an overdose, or it might be somebody who's admitted, say, to the cardiology awards or the respiratory awards, any ward really in Southampton General, that either staff, the patient themselves, or their family and carers are concerned about their mental health. So they would then refer the service user to the liaison service, who will come in, do an assessment, understand what the challenges is, what challenges that an individual may be experiencing, and then look at what support may be available. And I think it's about also understanding that patients can present in many different circumstances, not only to their GP, recognizing that, coming into an acute hospital for what may appear sometimes to be a completely separate issue may also present with mental health difficulties, whether it be the primary reason that they are there or not. And it's an opportunity to access services and access assistance. And what the psychiatric liaison team would do is do the assessment, help understand what the current issues or challenges are, and how best this person can be supported, be it in the community or if the patient requires inpatient care. So, for example, if somebody was seen in Southampton General Hospital and the psychiatric liaison team decided, well, actually, we think he or she requires a bit more support, they would then refer to community mental health team and say, can you please assess Mr. Smith, who's presented with these symptoms? This is what we felt. This is what we are concerned about. These are the current risks, and this is what we've discussed with him, and this is what we'd like in terms of support within the community. So again, there are many ways in which patients can be seen within secondary mental health services. We also have our assertive outreach team, and our assertive outreach team are quite a specialized team that look after our severely chronically unwell patients that require a lot more in terms of support. And as the name would suggest, occasionally, or with regards to mental health, for those that have struggled for a while or struggled to access services, it's really important that they have a team that's has the resources and the facilities to be proactive, to go out, see them, assist them with whatever it is that they need, whether it's access and support to getting to various treatments, psychology, whether it's support about leaving your home, making sure medication, for example, is being taken or is given regularly if needs be. And if they are experiencing any further challenges, looking at how we can support them better. But it's often a high level of support that's required for patients under the assertive outreach team. And April House is also our specialized eating disorders unit for those struggling with eating disorders. And again, we have access to medical support as well as a full team to help support. And often, many of these services, pretty much all of them, to be honest, you have access to advice and guidance. So, for example, for patients that may have an eating disorder or symptoms of an eating disorder, but for whatever reason has not been accepted within the eating disorders team, that doesn't mean that they don't have access to any of the resources that this team has. So often these teams, even if it is decided that you would not meet criteria or patients don't meet criteria for inclusion into the service, your GP, for example, or any mental health service or professional services are able to write to them to say, we understand that this referral has been declined, but we'd like some advice and guidance regarding these issues or regarding this matter, whether it be medication related or other matters that may arise. Pathways of care and treatment. So all of our pathways of care and treatment are evidence-based, and which means these are care pathways that are regularly reviewed and monitored to ensure that they are current, topical, and evidence-based. And in pretty much everything that gets done, we have service user and carer and family support and input, which again has had such a massive positive impact in directing the care and care pathways into very relevant care pathways, not just what sometimes professionals may think would be helpful, but again guided so that it is very relevant and pertinent to service users and their families. These care pathways are developed using best practice and nice guidance. Both medical and psychological treatments are always emphasized. So it's not just around medication, but again, it's about looking at a patient holistically, looking at, yes, medication, looking at psychological well-being, but also the social interventions that are hugely beneficial and helpful to most individuals. The care pathway also focuses significantly on recovery and personalization, or a very person-centered model. And with regards to recovery, we often use the phrase or the description within our community mental health services, but within mental health in general. And that is that we are working towards a recovery-focused model. And realistically, what it means is that, when patients come into a service, whichever service it may be, it's important to have a clear goal and idea of what we hope to achieve. And again, that is shaped very much and predominantly with the service user and their families and carers. And equally so, it means that actually we have a degree of throughput. And by ensuring that patients have access to a service, that their goals for treatment or coming into a service are regularly reviewed and achieved at the point of their discharge from the service, it then means that should they find themselves in a space where they require mental health services in the future, the services then have capacity to take on more. And so this idea where, previously, historically, community mental health services or mental health services almost held on to patients doesn't happen really anymore. We work on goals, trying to look at what needs to be achieved, what are the outstanding care, aspects of care that need to be highlighted, and once achieved and agreed, then often patients are discharged back to their GP. And this doesn't necessarily mean that there aren't ongoing challenges. It doesn't necessarily mean that a patient is now cured and there are no challenges or difficulties, but the goals that were set initially have been achieved. And sometimes service users themselves just actually want to break from mental health services, which you can also understand. So it's about timing, it's about where they are at, what their current goals are, and it's important to acknowledge and recognize that there's a time and place for everything. And if now's not the time, it's all right, because the service is designed in a way in which when the time is right for you, you have more of an opportunity to access that and get the care that, again, is very relevant to each individual. We do our best to offer choice and access to various agencies. We spoke about support for carers, and I think we've got a fair bit, don't we, Emma, in terms of carer support and access to support. We also have access to carer support workers within community mental health teams as well, to help carers and loved ones access support. And I think the acknowledgement and recognition that mental health difficulties, it comes with significant impact on patients, but also their loved ones and carers. And the impact on loved ones and carers can often be something that historically had not been as well recognized and acknowledged. We certainly have tried to change that model, because I think without family and carers, the success in terms of treating patients and ensuring that service users are getting the best possible outcomes is much more challenging. And if we're going to be asking family members and carers to support their loved one, we also need to support family members and carers. So there's a real emphasis on this. And it's really important that if you are a service user, or if you know somebody and are a loved one or a carer of somebody struggling with mental health services, that you're well aware that you can access support. In terms of psychoeducation, understanding what does schizophrenia mean? What does bipolar actually mean? Or what do they mean when they talk about EUPD, or emotionally unstable personality disorder? So it's about understanding the illnesses, understanding the impact that it has on you, but also understanding the support that's available for you as a family member or carer, should you require this. And so you're more than welcome to ask me any questions. The information that's gathered from access to the lighthouse goes on a system that we use within mental health services, which is the REO documentation. And what's helpful about this is that if somebody accesses Lighthouse the night before, and I come in on a Monday morning, for example, and if I'm about to see a patient or I have access to his notes, I can read what happened the night before. So there's that continuity of care. And sometimes it's really important to understand that even if somebody's just been referred to the services, for example, but you see a pattern that someone's accessing Lighthouse, it gives you a good idea that they're struggling. Gives you a good idea of the type of struggles that are occurring that may sometimes become or feel like it gets lost. So there is that continuity and also that background and information. And like we said, they're able to offer some advice and guidance, some advice and treatment advice during that time of difficulty for how patients can actually resolve it. Sometimes it's just about being able to access somebody that understands what you're going through, that's able to talk you through a situation and have a plan of action, which can be reassuring. And occasionally it's about speaking to somebody who's able to say, actually, things are really concerning and I feel like you need to go into hospital or you need to call 999 because this is an emergency.
I work for Silent Mind and we offer peer support in primary, secondary and crisis intervention. So we actually run the Lighthouse in conjunction with Southern Health. And so in the evening there are not only mental health nurses available to speak to people, but there are also peer support. And peer support, basically, we are not clinical, we're not medical, we are literally experts by having our own lived experience. So when you go and see something, they sound very prescriptive, we're not like that. We're kind of like, we can empathise, we can understand where you're coming from, we may have the same diagnosis as you, or we can understand lots of common traits between the different diagnoses. We also understand that you're not just your diagnosis, you're a real person, and that we can, we can walk alongside you and give guidance, and we understand that, your mental health is sometimes good, is sometimes bad, and we're just the same. So, so the Lighthouse is manned by both by peer support and the community mental health nurses as well in conjunction.
I think that the transition between children's services and mental health services can appear quite difficult and challenging, particularly since the services itself are different and are structured quite differently. But to answer your question, how does that happen? Ideally, if a patient or a service user is under the care of CAMS, at the point of discharge, or at the point of reaching age of 18, they would then be transferred automatically to the community mental health services, and that is often discussed within the team as well as with the service user and their family. If, however, they are deemed at that point of turning 18 or prior to that to not require further mental health support, then they are often discharged to the GP. Occasionally, and turning 18, for example, is a massive challenge, or a change in everybody's life. I think we can all very vividly remember that transitional space. And I think doing it with difficulties or challenges or mental health challenges just quadruples the challenge. And so occasionally, if a patient has been discharged from CAM services and then back to their GP but requires mental health services, then often your GP would refer to community mental health services or secondary services, but often highlighting that they have previously been involved with the CAM service or they have recently been discharged with the CAM service.
And now we've got the mental health wellbeing hubs setting up in your local PCNs, so there is access to mental health from your GP surgery. So if your child doesn't actually meet the criteria for secondary mental health care, then there is still access to mental health nurses and support through your GP, through the primary care networks, and we also have peer workers in the primary care networks as well.
Thank you. And how does one get to understand these criteria by which somebody might be acceptable into the service or not?
Do you mean the community mental health team or secondary mental health services? So I think it's public knowledge, isn't it? But or we should be able to access it publicly. It's not a well kept secret by any definition. But the long and short of it, so it's in our standard operations of procedure or our SOP within community mental health services. And it's interesting because I think GPs still ask us the same question because they frequently refer patients to community mental health services and sometimes feel that our criteria is rather stringent because compared to the referrals, the number of patients we end up seeing, there can be a bit of a discrepancy. And I think at that particular, again, to go back to your question, the answer to it is we need to be clear that the risks are high enough and patients have evidence of a severe and enduring mental illness. And I am completely, synthesizing this information to and oversimplifying it because I think that the criteria actually, when you look at a case, so when you look at a referral, GPs will tell us who the patient is, exactly what their difficulties are, what their challenges are, what risks they've already assessed and seen, and what sort of difficulties a patient may be going through at that particular point. And I'll give you an example. So, for example, if a patient is struggling with depressive symptoms and is a single mom to 2 young children, and the GP is saying, I'm struggling, I've tried various antidepressants, not sure where to go to from here, we would normally want to assess this particular individual because you have young children also involved within the home. So it's not quite as clear-cut as it may sound, and we rely heavily on the information given to us from the referrer. Sometimes we will also often agree to an assessment, and what that means is we will see the referral, feel like maybe there's a few unanswered questions or we are concerned, and at which time an assessment will be undertaken by the team. And if we then feel, based on the criteria, in terms of risks, if somebody is also just not coping, not able to get out of their home, not able to access services within primary care, for example, these would be all of the issues that would be taken into consideration when you're looking at whether you would accept a patient or service user into secondary mental health services.
Sorry. Thank you very much. Thank you.